All right, well, thank you very much, everyone. So I have a patient case, and we'll start, of course, the didactic portion, but a patient case regarding a pediatric patient that experienced methadone toxicity during their perioperative stay. So we're just going to go over, briefly through this didactic part, just the methadone basics, how it's being utilized, and then going to some of the pharmacogenomics literature and if there's any current recommendations. So we know with the World Health Organization, the analgesic ladder, this is a recently revised for probably the past couple of years to show more of a going up and down the ladder for pain relief. But we start off with step 1 using non-opioids and adjuvants such as our acetaminophen, NSAIDs, and adjuvants like the SNRIs, TCAs, muscle relaxants. If the pain is still there and there's still more pain, then we want to introduce opioids for mild to moderate pain like our codeine, tramadol, and hydrocodone. Step 3 in this ladder is using opioids for moderate and severe pain like methadone, which is our main discussion point here, as well as morphine, fentanyl, and oxycodone. And then step 4, using invasive or minimally invasive treatment such as epidural analgesia, nerve blocks, neurosurgical procedures. So focusing on methadone, it is a long-acting synthetic opioid that has the FDA labeling for treatment of moderate to severe pain, non-responsive to non-narcotic analgesics. It's used in detoxification and maintenance treatment for opioid addiction in conjunction with social and medical services. But we've been seeing a lot of use in perioperative methadone-based multimodal analgesia strategies like we do in our institution at Nemours Children's Health. We use this multimodal analgesia strategy because there's some data that shows that it lowers the length of stay, improve pain control, reduce the total opioid consumption, and get that early bowel movement in our operative patients undergoing some kind of surgery here. When we look at methadone, it's actually a racemic drug, so there's actually 2 parts of it. There's the R-methadone and the S-methadone. The R-methadone has most of its action on that mu opioid receptor, where we get that pain relief. Of course, adverse effects with this is respiratory depression. And then the S side has been reported to be an antagonist of the NMDA receptor, as well as some effects in the serotonin and norepinephrine reuptake inhibition. Some of the adverse effects with this side, though, has been shown to lead to some cardiotoxicity due to blockage of the voltage-gated potassium channels, and especially with that QT prolongation or tersosity point they monitor in this population. So to understand the pharmacogenomics of methadone, it's of course very important to understand the pharmacokinetics. 10 to 20% of methadone is excreted unchanged via urine, and that can vary depending on the urine pH level, as methadone is a relatively basic liposoluble drug. And a lot of the metabolism is done through the cytochrome P450 enzyme. So you can see the PharmGKB has that diagram on the left here, showing that S and R methadone, which is active itself, has multiple metabolites. I've seen reports of 8 metabolites up to 11 metabolites, but a lot of the inactivation is done through the cytochrome P450 enzymes to this EDTP metabolites, and then further down inactivated. In terms of metabolism by these CYP enzymes, CYP3A4 and CYP3A5 provides it's been reported as metabolizing about 70% of the drugs, the R and the S. CYP2B6 is more selective for that S methadone at 23%, and still has some effect on the R side. And then CYP2C19 is a little bit more selective on the metabolism of the R methadone, and then very little for the S methadone, and then minor contributions from CYP2D6 and CYP2C9 has been reported for the metabolism of this drug. Just to recap, R methadone is involved with that mu agonism, the mu receptor, and S methadone is involved with the NMDA and the essentially SNRI effect. So what are our current recommendations, or if any, for methadone? So the CPIC opioid guidelines, I know it focuses a lot on CYP2D6, OPRM1, and COMT, and only has recommendations for codeine, tramadol, and hydrocodone. They do comment, and they did evaluate other types of opioids, including methadone, where they have within the text saying that it is primarily metabolized by N-demethylation through CYP2B6. And then in terms of CYP2D6, it is a minor extent being metabolized by that, but it's unlikely to affect adverse events, dose requirements, or analgesia. If you look at the supplemental tables in the CPIC guidelines, they break down all the evidence and all the literature that they looked at for various pharmacogenomics implications. So CYP2D for supplemental table 6 and CYP2D6 and methadone says that pretty much their recommendation is normal metabolizers use the normal standard dosing. Other phenotypes, ultra rapid, intermediate, poor, there's really no effect or insufficient evidence on the methadone. OPRM1, of course, we would predict that if a OPRM1 variant, which codes for the mu receptor, is present, then maybe we have less activity on that mu receptor. However, this specific variant, evaluated by CPIC, says that it really doesn't have an effect or insufficient evidence for adverse effect, opioid dose requirements, analgesia, and the opioid dependence or withdrawals with multiple other opioids, including methadone. Same thing, same implications on the other variants for this particular gene. And then COMT, that R6, RS4680, and other variants also have insufficient evidence to have an association with the analgesia, opioid dose requirements, and adverse effect. So currently, the CPIC guidelines essentially has no recommendations at this time for methadone in that recent guideline. So let's take a look at some of the literature that's available. We mentioned in the PharmD there's pretty much like 4 or 5 CYP enzymes, but there's been multiple studies on how the other enzymes affect methadone. So going through just some of the common ones or interesting ones, there's these 2 papers looking at the past literature saw that CYP1A2, there's been really no impact on the methadone metabolism. CYP2B6, there's been multiple studies that show this link with association with decreased clearance of methadone. Therefore, we have increased trough and peak concentration and been associating that with adverse effects. And then CYP2C8, 2C9, 2C18 with limited no significant evidence. 2C19 is a bit conflicting, especially with its selective metabolism in R methadone. There's been some studies that can affect the levels there, but there's a lot of contradictory results as well in the literature. CYP2D6, really a lot more understanding is needed, but we already saw from the CPIC guidelines that there's really limited implications on methadone. And CYP3A4, CYP3A5, we say that it is 70% involved with the metabolism of methadone in the CYP enzymes. However, it was shown to be effective in the in vitro studies, but in the vivo studies, especially when you introduce a CYP3A4 inducer or inhibitor, it didn't seem to do as much of an effect compared to CYP2B6. So CYP2B6 in the literature has been overall the interesting gene to look at for methadone drug-gene interactions. Some of the other studies that came out in the past couple of years, especially for me in the pediatrics, focusing on, in this case, perioperative use of methadone. But these studies have looked exactly at my patient but looking at finding that CYP2B6 *6*6, a poor metabolizer, has a 2-fold lower metabolism of methadone compared to normal rapid, and these specific variants were seen to have higher incidence of post-op nausea, vomiting. In a study in 2022 looking at in vitro and in vivo data, specifically interesting that in vivo said that the methadone clearance was significantly decreased linearly based on the number of loss of function alleles of CYP2B6, but found no difference in clearance in CYP2C19 loss of function alleles or this P450 oxidoreductase enzyme, the POR, star 28 alleles. some of the pharmacodynamic in that ABCB1 gene in this palliative care population found that didn't find really any clinically actionable guidance to guide methadone in terms of the oral morphine equivalent or methadone dosing or even changes in QTC. So a lot of the studies that were published in the past few years focus a lot on that CYP2B6 as that kind of trending drug-gene interaction. So just to kind of conclude the didactic portion of this is, we are seeing methadone being used as is long-acting, has a rapid onset for modern severe pain, especially as a multimodal perioperative analgesia strategy. We see that 90% of methadone is metabolized through those CYP enzymes, and there's a lot of trending evidence for CYP2B6. And there's no recommendations at this time based on FDA labeling, Dutch Pharmacogenomics, or CPIC. But in the recent, one of the past CPIC meetings this year, they did mention that there are recommendations underway for CYP2B6 and methadone. So we may see something in the near future on this particular drug-gene interaction.